There's a lot of talk about stents, and the stents aren't made for veins, they're made for arteries. Neither one is true. The original stents were made for the liver. Some of you will have known people with pancreatic cancer or other problems in the liver, and they put in stents. That's where they were first designed for. Sure, the stents are going to get a little better, but the stents they've been using, they've used a lot. Dr. Hewitt and Dr. Rada probably have each put in 3,000 stents each, not into CCSVI patients, but into other patients. And they use them for treating vein problems, the azygos, the hemiazygos, the May-Thurner syndrome, which is something that happens in the lower part, down around, just above the belly button, roughly in there. So the stents can have a valuable place. Early on, we weren't comfortable with stents. Early on, some people use stents as small as 3 millimeters, which is the size they put into your coronary arteries. And they moved. Not good. Big deal out of the one in Stanford because it moved. Dr. Dake got shut down at Stanford because of that, or he'd still be doing it. Has he given up on CCSVI? No. But he regrets that stent that moved. Usually early on, we're anxious about it. But the interventional radiologists who've been using stents for years, they use a stent as least as big as the blood vessel, usually 10 or 20% bigger. So when they take an azygos vein and it's got a 10 or 12 millimeter distance across the main part of it, they'll use a 14 millimeter stent. It's not going anywhere. All right? Hemochromatosis is 1 in 800 people. MS is about 1 in 500 or 600 people. There's got to be a lot of crossover. We've got to study that group. Hemochromatosis means your body is, you just have a genetic variation and you're unable to break down the iron. It's pretty common. We, to date, typically have treated it by being bled every 1 or 2 or 3 weeks. Surprising how far we haven't come. We're still bleeding people. And that's all we're doing. But I've talked already about this to a couple of my friends who do chelation. One of them is in Alberta. He's probably the #1 complementary physician in Alberta. And surprisingly, as redneck and cowboy country as it is, it's one of the most accepting places in the provinces in the country for complementary medicine. BC is a very backward spot, typically. Anyway, those things aside, hemochromatosis probably will shed some light on this whole issue. I have talked to lots of folks with MS, and of course it's usually young women. Several of them have noticed their MS is worse just before their period. Almost everyone with MS that has a pregnancy gets a holiday from MS. When people are pregnant, I've never been there. When people are pregnant, typically their blood circulating volume is at least 50% higher. The fluid moves around much better. The vessels get bigger. They have to supply all the stuff to the womb. Is that why they get a holiday? I suspect it might be. The other group are the ones that have very low blood. I've got one friend now. She has MS. She's had the treatment already. And her ferritin is 8. That's very, very low iron stores. I have a feeling that she may be doing an automatic chelation on the brain. Now, I'm not suggesting you go out and bleed yourself down so you can remove this. But there's some clues in this that we need to look at. Most women, in my experience, get to the perimenopausal period, their MS gets worse. Is that because they quit bleeding every month? And their hemoglobin climbs? And their iron stores climb for the first time ever? Maybe. Maybe the increase in MS of the last 30 years, especially in women, because it used to be, not equal, but 2 to 1 or whatever. But it's increasing in women, young women. Maybe, just maybe, it's the iron supplementation and then the oral contraceptive and reduced bleeding that's making a difference. There's really important pieces here we need to figure out. And we don't need to figure them out just for MS. We need to figure them out for several things. When I see people now with MS, and I still see lots of people with it, I typically try to see where their ferritin is, and I'd rather have it in the lowest third at the moment until I know more about this. I also attribute a lot of this success to Facebook. I don't know how many of you have seen Scientific American. You know, it's a fairly prestigious journal as far as talking about what's happening. The February issue just came out last week, or maybe 2 weeks ago, says that social media, i.e. Facebook, is changing how medicine is practiced. And it is. It writes 2 pages on the Zamboni concept, and it gives both sides. It's maybe a little more biased than I would like, but I'm delighted they got it printed, because it isn't easy to move a new idea forward. Social media has probably moved us ahead several years much faster than we would have been, because it's allowed us to contact each other. I've got 3 kids, 27 to 32. They're all on Facebook, and their dad now has way more friends than they do. So that's very interesting, because it's such an excellent venue. And Facebook's not shy. If you're not honest and don't play the game well, you'll get burned pretty quickly. You know, the public is very rational and very concept. And I know now people within CTV nationally and CBC, and they watch what happens on Facebook, because this is what's happening, what's coming down the pike. So it's a shift. Many of you will know that already people are Facebooking their colleagues when they're in seeing their neurologist or soon after. And we as physicians must adapt. We must change. It's wonderful to get questioned. And we've got to get over the defensiveness that we didn't think of the idea, therefore it's not a good one. You know, there was a few angry people responded early on, and it hugely polarized Canadians. I've never seen the medical profession, and I've been in it. I graduated in '78, so that's over 30 years. I've never seen it as polarized as it is now, and I've never seen any group held ransom by one small group within it. However, with the help of patients, that can change. I think we can get this here. It's going to take a little time yet. I'm in Saskatoon a couple of nights. As many of you will know, the Premier there set aside $5 million toward this concept. That was a brave thing to do. And Saskatchewan, same size as Manitoba. It's a lot easier to shift a small ocean liner than a great big one. I'm affiliated with University of British Columbia. I'm in Land and Food Systems, which is the nutrition arm in UBC, as opposed to the medical school. And it's a little easier to shift a department like that than it is one here. I also like very much Debbie's concept, pieces of the puzzle. We are going to get a lot further. Unfortunately, they've tried to suggest that we're saying that this is a cure. It's not a cure. It's way ahead of everything else we've ever had. I'll grant you that. However, we must look at it as symptom control, because I firmly believe Canadian medicine will shift when it has to shift. And it will shift once we show that this saves money. It sounds grim, but it's true.